Hello everyone. Hi Sri Krishna, Manish,
Hello,
Dr.
sir.
Pandiraman,
Hello.
Dr.
Wonderful to
Bala,
catch up with you.
Dr. Ranganathan. Good evening.
Yes, sir. Good evening. Very
Thanks,
good
sir.
evening. Happy to see you on this program, sir. The sign is there for you. Chetan, are you there?
He's joining soon, sir.
Pardon?
Sir is going to join in 5 minutes, sir. He's in
Okay,
some
okay.
social function today.
Okay, he's attending. Till that time, you entertain us. Speak something.
Definitely, sir.
See, people are very sincere. They are the time you are given, they have joined it. But your program starts at 9. Till that time, what to do? Say something. Or ask Bhaskar Parekh sir to say something.
We are waiting for
Invite
our
him.
examiner to
Invite him.
join. We are waiting for our
Invite him.
examiner to join.
Dr. Manish, from what I understand, there'll be one person sharing the screen, right? Only one presentation
Yes,
that we speak through.
yes. I think Pramod Jog sir will share the screen and he'll discuss in between.
Sure, that should be good.
Manish, it will be for 1 hour, right?
Yes. Mainly it will be 1 hour. After that, there'll be like usually it lasts in 10, 15, 10, 20, and then some question answer are there in the chat box. Then we'll discuss that.
Okay.
Usually we finish by 10:30, 10:40 in
Okay.
routine.
Okay.
Here in Ahmedabad, pediatricians are quite free, sir, right now. Work is very less.
I think everywhere it is the same picture.
Everywhere it would be same, yeah.
Everywhere it is the same picture. And as such, pediatric practice is going down day by day.
Yes, yes, definitely. And this
Yeah,
year,
for-
it really feels like
yeah,
this
indoor,
is
at least indoor practice has definitely reduced a lot. And vaccinations which were there with us, also many of them have been taken
yeah,
away
and that is going to reduce day by day.
day by day. Yeah. So start in.
Sir, there is a saying. Sir, there is a saying in
Ah,
Hyderabad. Up to Diwali, everything is up, happy.
ah,
After Diwali, it is Diwala
Diwala.
for a doctor.
And after Holi, everything will
So,
start again.
wiped out totally. So, whatever commitments,
Hyderabad also
whatever
same picture,
payments you have to
Dr.
make.
Dr.
Pardon,
Rangnath. Hyderabad
pardon,
also
sir?
it is going down.
Yes, sir. Yes, yes. It's totally, clinics are empty.
Mm-hmm.
OP is, ours is a hospital, so OP is almost nearly empty.
Mm-hmm.
Teaching institute, so we have some cases which are chronic cases, they do come. Otherwise, there's nothing.
You must be getting tertiary
We,
care.
yes, that's all. So
But
those
Kanchi
people who are having
Kamakoti, I'm sure is
arthritis,
doing very well. I am Dr. Bala is always busy.
Good evening, sir.
Bala will be always
Ah,
busy.
Always busy.
hi,
Always
Pakul,
busy.
Hi, how are you?
Pramod.
Nice
And
to
our
meet
exam
you.
Pramod
Nice
Jog
to
also,
see
also very busy. Dekho, he has joined just at last minute. Till then he
No,
was very
I'm
busy.
not, I'm not very busy. I have restricted my practice. I'm not busy. Now I'm leading a quiet, retired life with minimal practice. So there's no way I want to be very busy. Yeah.
Fantastic, fantastic. That's the way.
All fine. Pramod, how are you?
Pramod last OPD patient को देखने चला गया.
No, not like that. I am here only. I am removing my cot from the background. Okay.
Great.
One minute. 1 minute.
आज तो सब वायरल इन्फेक्शन को हंसी मजाक से उड़ा देंगे.
Mm.
I love his heading to the slides. I believe it is intentionally hazy, Dr. Pramod sir. The headings of the slides are all, they are meant to capture your attention and to confuse you.
No,
Namaskaram, Balasubramanian sir.
no, not like that. I just okay. Whatever view I'm taking, there are many things coming back to back.
You can blur your background.
Uh,
2 minutes to go.
Who else is joining now? Palniraman has joined and gone back, I suppose.
Kulkarni sir, Pramod Kulkarni sir is left. Paniriman sir had joined and he went here.
Pramod Kulkarni is joining, na?
I'll call him.
Yeah, call him. Dr. Pramod, other Pramod is joining, no?
yes. I hope they will. Sometimes
I'm calling him.
they keep
Yeah.
working. Maybe they are
Please
working
join
in
the
OPD.
session.
Okay, so how many of you attended the indoor meeting? I was unable to go.
Indore, I was there.
Darud doctor. Acha. What did you speak on?
Indore, I was fever with rash. I talked on fever with rash.
Okay.
Yeah. Yes, sir. Sir, shall we start, sir? Daru, sir?
Mm. Time is
Yes.
time.
Yes, yes. So good evening, friends. We are meeting once again on this ninth link of Super 11 that we discuss on every last Thursday of every month, and where the experts give their opinion on common routine topics related to Chetan Trivedi sir is there, so he can start. Welcome, sir.
No worry, you continue, please, Manish.
Yeah, yeah, sure. So today also is one of the most common practice, especially in coming months. So we are going to deal with many viral infection, and probably nowadays we are moving more towards from bacterial infection to viral infection and inflammatory disorders. So this is one of the most important topic in today's day-to-day practice. And for that, who else? None other than Dr. Pramod Jog sir is there. We're going to moderate today's session. And our experts are Dr. Bakul Parekh sir, Dr. Sri Krishna sir, Dr. Palniraman sir, and Dr. Pramod Kulkarni sir. But before we start, I request our chairman, Dr. Anand Daru sir, to say a few words.
The topic is very nice because if you can make a diagnosis of viral, the misuse of antibiotics will stop. The main aim is to control the AMR. In that viral diseases, if identified and confusion is cleared, then there is a lot of support for our program. Continue. Thank you.
Yeah, thank you very much, sir. And I request Secretary Dr. Chetan Trivedi sir to welcome.
Hello,
Yes, yes,
are you able to listen to me?
yes.
Am I audible?
Yeah.
Okay, okay.
Yes.
Sorry. Welcome all, dear friends. After a break of say 1 month because of Diwali and our IAP elections, now we are back to the business, and that is academic journey continues. And so, since this Super 11, the brainchild of Dr. Bala sir and the able leadership of Chairman Dr. Darur sir, it has reached to ninth link. Maybe next month it is a December, it is a 10th link. So I hope everybody is enjoying and will continue this academic activity with the blessings of Dr. Bhaskar Shenoy, incoming chairperson 2025 of PIDA also. So thank you so much and happy learning. Thank you.
Thank you. Thank you. So today our moderator is Dr. Pramod Jog sir, who doesn't require any introduction. And probably people are eagerly waiting to listen to him. He will always do something different from rest of our sessions. So we are waiting for you, sir. Welcome, sir.
Thank you. Thank you. Shall we start?
Yes,
Yes, sir.
Okay, no problem. Just
Pramod,
give me 1 minute. Huh?
Pramod, another Pramod is
Yes.
missing. Another Pramod is missing.
Yeah, he
He's
will
joining,
come.
sir.
He
I
will
just
come.
talked to him. Yeah, he's joining.
Yeah, yeah. No, he will come. Huh? No problem. Just 1 minute. Huh? Okay, we will now go back to the first slide. Very good. Okay. Right. So, my dear friends, today we are going to discuss the common viral infections, and the topic is let us clear the confusion. Okay, and I am pleased to have BP Bakul Parekh, PK, that is Pramod Kulkarni, the infectious disease specialist, Palaniraman P, and RSV. RSV doesn't stand for the respiratory syncytial virus, but RSV is, of course, RSV Krishna. Okay, so of which I definitely know that everyone is a rational pediatrician, and I will try to bring forth certain important issues related to viral infections. And many times, these days we have to know quite a few things about viral infections. And the goal of today's meeting is basically to review the common viral syndromes in the primary care, to understand the current standard rational management, and to highlight the anticipatory guidance and infection control. I must acknowledge the inputs from Dr. Pramod Kulkarni in preparation of this presentation, and I'm glad that everyone is very much present in this panel. And the word viral has become so viral that I will tell you, recently there was one small little child who came to the OPD, and the child was sitting with the doll, and this small little child had fever, and this child was consoling the doll, saying, don't worry, it's viral, you will be all right, don't worry." So even small little children these days know that there is something like a viral infection, and that's why I always say that the word viral itself has become really viral in the community, and particularly in the parents. So I would first request Dr. Pramod Kulkarni to tell us as to what all are we witnessing in the post-COVID period? Because during COVID, all the illnesses were almost in hibernation, and after COVID, there has been definitely a bit of a change and upsurge of certain viral infections. So, Pramod, could you just tell us as to what is your experience about the post-COVID infections, particularly the viral infections?
Good evening, everybody, and thank you very much, Zok sir. To share, let me speak out experience of all the pediatricians across India. So post-COVID, we had seen due to the isolation measures so scrupulously followed by the population out of scare, but definitely it helped to keep away all the viral infections. And not only that, COVID had swept out all the other viruses and dominated the world for almost 2 years or so. And thereafter, once it was a used to virus for everybody, all the human beings and the population, and we had good antibody levels. Then the COVID surge got down, and we got the old enemies which were sleeping or hibernating for 2 to 3 years. We immediately got all the vaccine preventable diseases coming up, especially the viral one. We had very bad measles epidemic. Then we had the adenovirus epidemic. This year we have all everything going up again, respiratory viruses as well as non-respiratory viruses. Dengue, chikungunya, everything is on rise. Everybody must be agreeing, should agree, and will agree that we are seeing the viral infections with more vengeance post-COVID era. And we all know the reasons. There was no exposure, so the natural protection or immunity given by these natural exposures was down, and the kids born during that period didn't have that immunity from maternal side as well. And suddenly there was increase in huge pool of susceptible kids, which fell prey to these viral infections, which appeared more severe, more atypical, and more worrisome. Uh, of course, after 3 to 4 years now there is little stabilization of the viral epidemics, but still we are seeing every time a new virus coming up with a different presentation and different severity. That is what I would like to share. Thank you very much, Zoksa.
Thank you, Pramod. Now, Dr. Bakul, just to begin the topic, I would like you to inform our listeners as to what are the clues to the viral etiology. You may take the clinical clues, and maybe Dr. Palani can take the laboratory clues.
Yeah, so thank you, Dr. Pramod and Dr. Pramod Kulkarni to start the ball rolling. And as Dr. Ranganath said, we have to identify viral infections as far as possible clinically so that we don't abuse antibiotics. And I'm very sure that if we go into detailed history, definitely we can, up to a level of 85 to 90%, be very sure that we are dealing with viral infection and not any other infection. So usually clues will be fever will start maybe high or maybe moderate intensity, and then over a period of 3 to 4 days, it starts subsiding, and maybe over 7 to 10 days it will go. Interfebrile period chai will not be very toxic. There can be a family contact or a contact in the neighbor. There can be a breakthrough season, or maybe there are some seasonal viral infections which are very common. And of course, you will be having some symptoms before the actual viral infection, like malaise, body ache, and myalgia. As against in viral infection, you will get localized infection. Maybe you can find a focus which can be a pustule, or maybe child can be very sick looking, and even without fever also child will be looking very sick. So all these features, if you go into the details, will definitely give you a clue that you are dealing with a viral infection.
Thank you, Bakul. Now, in your experience of so many years, do you really agree with all the facts that you are told? That means the child is definitely normal in the interfebrile period. And do you, or maybe any other panelist, Dr. Palani, that means these are all the things which are routinely discussed in our meetings. But then, do you really feel that all these are, true to the best of your experience of all over years?
So Dr. Pramod, if there is an immunocompetent child, I'm very sure that 85 to 90% will be very confirmed, and you'll be very comfortable in putting your diagnosis as a viral infection if you look at all these features. But sometimes, of course, there can be aberration, there can be exceptions to the rule. So these are all general guidelines. You cannot be dogmatic, but of course, this will give you a better picture, and you may be able to shorten your differential diagnosis before you proceed further.
Okay, and then Dr. Palani, could you just tell us about the clues from the lab investigations?
Dr. Krishna wants to say something. Dr. Krishna wants to say something.
Yeah.
Sure.
Namaskaram, everyone. A pleasure to share stage with two presidents of IIP. Just wanted to convey one point, sir. A lot depends on the hydration of the child. In fact, it could still be a viral infection, but the interfebrile period, if the child is dehydrated, then the child continues to be sick. So please look out for signs of dehydration. Most of viral fevers result in high fevers in the first 48 hours. And if the intake is lesser, the child goes into dehydration, and that might contribute to that sick look. But most of what you have presented in the slides are all true.
Okay, thank you. And then Dr. Palani, could you just tell us about the lab investigations? Because many times, we have confusion about the different series of the white blood cells. Yeah.
And here I want to give at least some basic clarity when you look at the lab investigation. Because most of the time we come across the acute infection in pediatric practice. We mean acute infections are virus unless otherwise proved. And the acute infections usually present with fever. When we come across fever, we should always follow the three-step approach. Is the baby sick with fever? Is the baby is fever with focus or fever without focus? If the baby is sick, we all know it is mostly a bacterial infection, and we decide accordingly. We admit it and investigate and treat. No problem. If the baby is having focus, like for example, with mumps, with hand, foot, mouth like lesions, or with the enanthem or with exanthem or any rashes, we know mostly we are dealing with what is the thing. So it is not at all a problem. When we look at the lab only when there is no focus, and particularly after 48 hours, we want to know whether am I dealing with still a fever without focus, still a viral infection or a bacterial infection. Because here the bacterial infections are very less. Occult pneumonia or occult UTI is the most common occult infection. But even then, majority of the fever without focus are mainly due to viral infections. What are the viruses? Like human herpes virus 6, that is exanthema subitum. Till the exanthem occurs, it is a fever without focus. And many enteroviral infections, many adenoviral infections, and usually and echovirus infections, they present without focus. But we want to get a clue from the lab. So what is the easiest lab we can do is CBC. That is which is available throughout the country, and even in the periphery it is available. So majority of the viral infections, when you look at, they will produce leukopenia with neutropenia. That is mainly the transient neutropenia is very common, associated leukopenia. That is a common one, and without thrombocytopenia. Some may present with leukopenia, with thrombocytopenia, with high hematocrit. It is a typical of dengue. So that is especially the CBC gives the diagnosis in dengue. The remaining viral infection like leukopenia without thrombocytopenia, you have for other infections, viral infections you can get. Sometimes viral infections will produce leukocytosis, lymphocytic leukocytosis. For example, the total count will be 17,000 and lymphocyte will be 80%. Absolute lymphocyte count will be more than 10,000. But see to that hemoglobin is normal and platelets are normal, so that we are not missing a malignancy. For example, the echovirus, parechovirus are known to produce infectious lymphocytosis. And sometimes when you look at the smear, there will be infectious mononucleosis pattern also sometimes. So these are the 3 to 4 ways. And rarely, like in adenovirus season, which can mimic a bacterial infection, producing neutrophilic leukocytosis. Neutrophilic leukocytosis is characteristic of bacterial infection, but it can occur in viral. Mostly you will get a leukopenia without thrombocytopenia. At times in dengue, you will get leukopenia with thrombocytopenia. And rarely and sometimes you'll get lymphocytosis and with a lymphocytic lymphocytosis. These are the characteristic patterns. And when you look at the CRP, usually it will be less than 20 or less than 30. But at times exceptions are there, like adenovirus, where you can have the CRP as high as 150, 160 also. So these are the exceptions. Hope I am clear.
Just to add to the valuable things which you have said, this time we had very bad chikungunya, which was marked by lymphopenia and high CRPs, very high CRPs and ESR. So that is another thing we must consider.
Oh,
But one thing is,
Thank you.
I like that is that the CBC usually has a very low sensitivity and specificity for any diagnosis. So ultimately, it should be a sort of a correlation with the clinical picture most of the time, rather than depending only on CBC. And lymphopenia, if it is below 1,000, of course, it says that your immunity may be very low.
Again, all these point, all you know very well when none of them individually is diagnostic. Most of the clinical diagnoses are based on scores. Likewise, here we have to entertain all the clinical parameters as well as lab parameters together towards a possibility of bacterial rather than one telling you about bacterial possibility. So
Correct.
more points in favor will be more suggestive of bacterial and likewise.
and last point to add, as Buckles are told, 80% of the chances, particularly, they have a characteristic interfebrile period. There will be no sickness and they will be playing, and the CBC will be like this. So it will be add to that. The CBC will add to that thing, but it will not actually diagnostic. It will add, except in dengue, which is diagnostic. CBC is diagnostic.
Right.
Sure. Okay. So now, coming back to Dr. Sri Krishna, I will be asking you something about common cold. But before that, I must tell you that viral respiratory syndromes, they are the most frequent childhood infections. They are acute, generally uncomplicated and self-limiting. And the typical duration is about a week to 2 weeks. And then they are all most commonly because of the rhinovirus or RSV or influenza, or it could be adenovirus or enteroviruses or coronaviruses or the human metapneumoviruses. And Dr. Krishna, you can just tell us some myths and facts which are related to the upper respiratory infections, particularly the common cold.
Yeah, thank you. These are very common points and very important practice points as well. The first myth is on the type of discharge. It's not as if yellow and green discharge always indicates a bacteria, not at all. The fact is that it could just indicate their enzyme activity. Now, can you go back one slide, sir? Two important words that Dr. Pramod Jog had presented. Please look at the second point where it says generally uncomplicated and self-limiting. And the third point, most important one, and many a time we also get scared, not looking at this important aspect, 7 to 14 days. Each disease has a course. The viral upper respiratory infections have a course of 7 to 14 days. You cannot expect it to come down in 48 hours. So now go to the next slide, sir. Yeah. So, and any non-improvement in 3 to 5 days does not mean bacterial. The fact is that the course of upper respiratory infections, if it is caused by a virus, tend to take 1 to 2 weeks. Don't expect everything to just remarkably improve in a matter of 48 hours. They take their own duration. And the most important point we all face from the parents, child gets better, fever is down, but the cough doesn't go away. We need to remember that the cough has its own time period of at least up to 21 days. Some of them, yes, do get better. There are a lot of factors. We'll discuss that in further slides, but the duration is for 7 to 14 days. Middle ear pressure and the sinus related abnormalities are bacterial all the time. Could not be. The most of the time, these symptoms and these additional features could be brief, self-resolving, and could be part of the clinical syndrome. And the last point, it is thought that bacterial superinfections are very common. Often the parent who wants an antibiotic for his child tells you this child is getting a bacterial infection on top of his viral infection. It just doesn't come like that. It doesn't come to everyone.
Can I add something?
Of cases would it happen? Otherwise, most of them are viral infections which are generally self-limiting, would last up to 7 to 14 days.
Pramod bhai, can I add something?
Yes, Bakul.
A common
Please.
situation in our OPD practice is many times the parents will come and say, my child's fever is not going down, even after giving whatever we had counseled and given some the paracetamol and other thing. But most of the time we see that child is otherwise comfortable. So it's very important to stress that response to paracetamol is not the fever degree of temperature, but the comfort level of the child. So if child is becoming comfortable even with 101 fever, when he was given paracetamol it was 102 and it is 101 now, parents will feel, doctor, something is wrong, please give antibiotics. But then we have to counsel them that response is seen by the comfort of the child and not by the degree of the temperature.
Very important point, sir. Treat the child. Don't treat numbers. Don't treat temperatures. Don't treat values on a report. Treat the child. Keep looking at the child. That is most important.
And as Krishna told, all the practitioners should know the epidemiology as well as know the natural history of the disease and know the percentage of the bacterial complication, how much percentage will go for complication. Then it will be easy to treat and reinforce the parents.
Right. That's very important, so that we should not take this point that, the child may get superadded infection, so I am giving antibiotics. So that should be out of the mind. And then, Dr. Palani, you can just tell us a bit about the complications of the viral respiratory syndromes.
So before that, I want to actually ask a common question to Pramod, who is ID specialist. Difference between the common cold and flu. Majority of the times, they both are getting confused in the public. Flu as well as common cold. Common cold is different, flu is different. Pramod you can tell before going to the next question?
Basically, these two are clinically different infectious syndrome. When we are calling influenza, we label it as ILI, influenza-like illness, which is dominated by fever and toxicity,
Yes.
and less of the respiratory symptoms. If at all anything is prominent, it will be cough. Okay, while in URI, the fever is not that high, the nasal symptoms will predominate. Nasal, eye symptoms, cold, cough, congestion will predominate in URI. While in ILI, you can get sore throat as typical component of the influenza-like illness. And usually you will find, depending on age, this clinical segregation into two infectious syndromes is done. There is an overlap, but older children, you will think of ILI. Younger children, you will think of viral URI.
Okay. Because majority of time, both are given, actually, people think both are the same. It is not so, as Pramod told. Yes. Yeah. When it comes to...
You can Yeah, continue.
When it comes to complication, as I already told, Krishna told, when you know the natural history, you can say whether it is a complicated URI or a simple cold or a complicated cold. We want to know if it's a simple cold or a complicated cold. For example, in a simple cold, what happens? First 24 to 48 hours, there will be fever. And then the fever settles. The first one to settle is the first 48 hours fever, number one. And second thing is, first 24 to 48 hours, there will be watery running nose. Then it becomes mucopurulent running nose. Then it becomes purulent running nose. Again, it becomes watery. And finally, by 7th day or 8th day, the running nose will settle. Whereas the cough starts after 3 to 4 days and settle after up to a period of 14 days. So anything away from this graph, for example, if the fever is severe and going beyond 3 days, and along with the purulent nasal discharge initially itself, normally initial 2 days, there won't be purulent discharge, it will be only watery discharge. If there is high fever with the purulent discharge, which is known as acute presentation of sinusitis, number one. Number two, as already I told, after 48 hours, fever will not be there. But if the fever occurs during the latter part, that is known as a double sickening, it is known as, again, second type of sinusitis, number two. Number three, sometimes, usually we say it should settle by 10 to 14 days. By 10th day also, it is not settling and the child is not getting out of the problem. The child is day by day, it is not coming out. It's still sick and the cough is also going around. The fever is also low-grade fever is going around. This is the commonest type of presentation of prolonged presentation of the URI symptoms and signs, which is known as the prolonged phase, which is also a case of sinusitis. And you should know which age this is common. This is common only above the age of 3, not less than 3. We should mind it. We should not diagnose sinusitis right and left less than 3 to 4 years. Because, why? Because less than 3 years, the eustachian should be short and easily the child gets complicated with otitis media rather than sinusitis. Otitis media is the commonest complication, is the lesser age group, and sinusitis occurs little older age group. So when you know this, you won't unnecessarily diagnose sinusitis in less than 3 years age group. So this is the way I go, whether I am dealing with a cold or a simple cold or a complicated cold, which is around 10%, 5 to 10%, where I will start antibiotic.
Can I add one more thing?
It's very good.
Pramod bhai.
Yes, please.
So I always follow a dictum that if any sign or symptom is not behaving expectedly, behaves unexpectedly, think of something, some complications, think laterally. I think that will guide you to the right direction.
Sure, sure. You may continue by telling us about the diagnosis and the investigations if required in a child with viral infections also.
So here, as we had discussed, diagnosis is based on definitely history, clinical picture, epidemiology, the season in which child is coming. Like for example, in monsoon, we'll definitely think of dengue, and during COVID season, we always thought of COVID first rather than anything else. And of course, if you have an history of exposure with the family member having the similar complaints, or maybe in the neighboring system, or maybe in the community, then again you will think that your child is suffering from the same disease. And as per the age, as Panli Raman already said, younger age group, you will think of otitis at times, and later maybe sinusitis. So all these things are going to help you traveling, so if you have traveled to a particular area. So all these things will help you in clinically picking up the diagnosis. And if you feel that something is missing and is not fitting into your diagnosis, then and then only you will investigate and correlate accordingly. But most of the time in viral infection, once it is clinically diagnosed and is behaving as expectation, there is no investigation required. You have to just give symptomatic treatment, good hydration and good ventilation. But from the prevention point of view, of course, you have to take certain precautions, like it's not spread to the other kids. Like you may not allow your child to go to the school so that the other child is not getting infected. You may not be allowed or maybe you should get hydrated. Don't use your fomites from one person to another. So all those things you have to take care. Hand washing is very, very important, especially those who are taking care of the child. And while sneezing or coughing, as we have learned in COVID, you have to use your elbow rather than your hand. So all these factors will help you, but most of the time investigations will not be required unless and until there is an epidemic going on, like say a case of dengue. We have to do NS1 if required in first 3 to 4 days, or later on maybe IgG, IgM. But in general, your infection control, proper public health issue, and proper counseling. So basically, you have to counsel your parents very well rather than doing investigations in a case of viral infection.
Yeah. I agree, Bakul, with you. Why I asked you this question is for one more reason, and Dr. Pramod, I would request you to answer that. When we were residents, there were no investigations at all available. In the diagnosis of viral infections, but now the PCR diagnosis has become very, very commonly available, at least in the metros and the corporate hospitals. And many times, the parents also have changed. Usually those our IT sector parents, which I call them as the inquisitive and the troublesome parents, they many times, they want the diagnosis. And then it's really very difficult to convince them that, this is viral, this is viral. Some or the other, they want a diagnosis. And then on one side, we know that there is no necessity of some of these investigations. But then what is your outlook, and when do you take the help, or when you resort to diagnosis with the help of these panels and the PCR? So these are the things which are available these days. So Pramod, maybe a brief comment from you about this.
I agree with you with the advent of the moleculars and availability in many of the metros nowadays, and the class of parents, as you said, educated class of parents who are very keen on these things. But we have to follow the basic principles of diagnostic stewardship here. We will do any investigation and tell the parents also, if at all it is going to change my management or change my diagnosis, then and then it is welcome. I can only think of investigating a child for URI or common viral infection only if the child is having unusual immunological problems, that is, immunologically affected host. That is the only high risk where I may think of doing it. Otherwise, there is no role. Only other thing is the epidemics. Now about the influenza, measles, and COVID, all we know. These are the exceptional situations when it is a big outbreak or epidemiological problem of public health significance, then it might be indicated. But for common pediatrician in practice, to current practice standards, there is no role of advanced moleculars for diagnosis of common viral respiratory infections.
Pramod, I may add
I,
that if a patient is admitted
yes,
in
please.
ICU with severe infection where you don't have time or when you are confused as to what to treat, and or maybe you are dealing with a case like encephalitis, there you may go for biofire and come to a conclusion. But as Pramod said that in usual OPD day-to-day practice, not many investigations are required.
Yeah, I actually, why I asked you this question, Pramod, is, many times, the viral infections are obviously seen clinically. However, the fever doesn't go down for 5 days, 7 days. And then, as we always discuss about certain viruses like adenovirus, which may, have prolonged fever. Many times our colleagues, they already start with antibiotics like amoxicillin. Fever doesn't go down. Then what are the particular situations where PCR would be of help in the diagnosis? Say, just as I said, in case of adenovirus, for example, or influenza, for example. So I just would like you to tell as to what are the situations where it is really useful in the clinical practice for our practitioners.
To say about the indication, number one, if the child is critical, as said by Bakul Bhai, if the child is critical. Number two, is the child immuno-incompetent, that is the second situation, or high risk. These are the only 3 points where it is indicated. And if you do it in these indicated scenarios, the concordance with the actual pathogenicity is very high with the PCR viral panels with the clinical syndrome. Apart from the common rhinovirus isolation, as we know, can be positive in anybody at any time of time, any time, especially in kids. So, if there is pneumonia or critical LRTI or non-responding or in indirect gain of antimicrobial stewardship, if you want to cut down the antibiotics in an admitted child, in these are the scenarios where it can be really helpful. But if you are doing it, you must use the results of it to cut down the antibiotics. That is very important.
And especially in the case of adenovirus, it is usually a common organism seen in nasopharynx. So many times when you do biofire using nasopharyngeal secretion and you get adenopositive, you don't know really exactly it's an infective organism or maybe an commensal. So you have to ultimately clinically correlate, otherwise positive predictive value will go down.
So unless you have a clinical, a high probability of that clinical infectious syndrome, as in influenza, if you have severe pneumonia, or in adeno, if you have conjunctivitis with persistent LRTI or critical LRTI, in that case, definitely the isolation or PCR positivity will be concordant. If there is no clinical syndrome suggestive, then there is no use or no validity of the isolation of particular PCR nucleic acid of any virus from PCR. So it is always the clinical scenario or background which pushes us to do the PCR, not otherwise.
Sure. Yes, Palani. Yeah.
Thing is, the one very common thing missed is when there is the fever is going on beyond the 48 hours or 72 hours. Very, very important thing is small babies less than 5 years, failure to do otoscopy. Because majority of time we picked up otitis media only by otoscopy, not by clinical symptomatology. They won't tell, and because of the fever, the child is going to cry, and they won't tell. Definitely by otoscopy, it is actually otitis media is a otoscopic diagnosis. It's not a clinical diagnosis. So unless you do what I have picked up many cases of otitis media as a cause for the fever, that the fever is prolonged URI. So this is the thing the practitioners have in mind. Then comes the adenovirus and other things where you can have a pharyngo, that is evidence like pharyngitis along with the conjunctivitis, like etc. And the season is going around everywhere. The season is going around, and neutrophilia is there. CRP is high. You will think about adenovirus. But most common thing is don't miss otitis media in a fever going on in a young child.
Sure. We will be coming back to otitis in a minute. Before that, Dr. Sri Krishna, just tell the audience about the interventions which are really useful and which are really not useful in a child with viral infection.
Yeah, viral infections last a course. We have just seen that. Now you need to make the child better. See, you're not here to drive the virus away in 24 hours. That was never our intention. And the parents also want the child back to a reasonably normal health. Now, there are a couple of interventions which we're not very sure of the benefit, but they are inexpensive, unlikely to be harmful. One of the very important ones is to maintain hydration. Any dehydration will make the child dull, also increase the body temperature. So make sure the child is taking fluids. They are not very receptive for regular feeding. Please make them keep sipping little fluids through the day. Warm water is a wonderful medication. Please use it. Similar one is saline nasal drops. Cool mist humidifier. As per WHO, it has no specific role. Can try throat soothers. Honey again has been recommended in IAP STGs as well to have some role, but strict no for steam, strict no for vapor rubs. Please do not recommend these for children. There is no evidence which is supporting any vapor rub or steam. Next slide, sir. And a big no, no, no. I think it's about 7 or 8 times that Dr. Pramod has written no antibiotics. You cannot open your neighbor's door with your key. Viruses are different from antibiotics. You cannot treat a virus with antibiotics. There's no other way to say it. Please do not use antibiotics. Antibiotics are not antipyretics. Antibiotics are not antitussives. They just kill a bacteria if it is there. So please do not use antibiotics unless you have an evidence, unless you are convinced clinically that there is a bacteria. Please use it only for a clearly diagnosed bacterial infections. And OTT and cold and cough medications, again, no evidence in less than 4 to 6 years. Bronchodilators, again, only in cases of asthma where there is distinct bronchoconstriction as a rescue therapy. Otherwise, they are not here to treat cough. They are not here to treat the fever. Antipyretics only for fever with discomfort. Please take a minute to explain to the parent that a slight body temperature is good for the child. It is meant to slow down the systems, just like a machine slows down when it is hot. So the intent should be to treat the child. A little fever is okay. Discomfort is what is the major concern. Please continue to use only paracetamol. No evidence for anything beyond paracetamol. Perhaps ibuprofen for more than 6 months of age. Antivirals in time to come, and the place where I practice in Hyderabad, it has now become a mainstay of treatment. It is useful only for influenza, ipratropium nasal spray in more than 5 years, non-responsive rhinorrhea.
Good evening, sir.
Now, with this, Dr. Palani, I am quite aware and I am proud of you that you are a promoter of a strong rational antibiotic therapy in your practice. And now this is a different question for you, that we all always say that no antibiotics for viral infections. But with your experience of so many years, have you ever repented not giving antibiotics? This is just a question which I thought I will ask you. Yeah.
Good evening, sir. Good evening, sir. Sir.
Yes. Yeah. Okay. So Palani, I just wanted to know whether, have you ever thought that, oh, I should have given antibiotics? I know that in majority of the cases, we really do not require antibiotics. But do you feel retrospectively that there was one case, somewhere I should have given antibiotics, or, something different happened and the judgment was, rather different and, something like that?
And so far, never, sir. To be frank and honest,
Okay.
so far, never. Because even missed it, because another 3 to 4 days, it is going to come. All our bacterial infections which are treatable, even if we miss, they are not life-threatening. So we can easily pick it up even later also, even if you miss it.
Pramod, here
Wonderful.
I like to
So
stress on 2 points. Pramod.
yes.
Dr. Pramod, if you allow, I want to press on 2 points.
Yes, please,
Yeah,
please,
so one
please.
is the comment about antivirals. Many people nowadays are using oseltamivir for any sort of viral infection, no? Thinking that, okay, it's virus, so let's give something and let patient be satisfied. But please avoid using that. Otherwise, that drug also will get useless. And secondly, about the balms and Vicks and other ointments which you apply, with camphor. So we had 1 or 2 patients in my hospital who came with convulsions because of that application of Vicks on the forehead and chest, because that camphor gets absorbed through the skin and can lead to convulsions. So better to avoid this, as well as misuse of antivirals also, not only antibiotics, misuse of antivirals also.
So we are coming to the same case, and this case I'm particularly going to ask Dr. Pramod Kulkarni that he was a 3-year-old boy, and he came for a fever, cough, cold, and progressive breathlessness over 3 days. He was tachypneic with low saturation of oxygen, and this was the X-ray, which was suggestive of ARDS. And he was admitted to the PICU. He was ventilated, and he received oseltamivir and supportive treatment. As we all know, that oseltamivir is given for children with respiratory distress who are hospitalized. And the throat swab showed H1N1 positivity. He was ventilated for 3 days, and then he was all right. So the question I wanted to ask you, which Dr. Bakul was also referring to, is are there any situations where early oseltamivir should be started? And what is your opinion about this oseltamivir? Because many of our colleagues I have seen, they use antibiotics and antivirals together, many times out of busy practice or whatever it is. But right from day one, I have seen people starting with amoxicillin or amoxiclav along with oseltamivir, simply either because they are unable to diagnose or they want to cover up viruses and bacteria together, whatever could be their logic in their minds. So what would be the proper approach in children where you are in a dilemma as to what is going on in this child?
So basically, we are dealing with a probable influenza. That is the question. So firstly, let us look at the current circulation or status of influenza circulation in the community, number one. If it is supported by the government data or wherever available, the virus studies being used in higher institute, you can really make out whether influenza is circulating right now or not. Number one. Number two, on OPD basis for oseltamivir is indicated only for high risk category kids, not for all patients. Only with high risk category, that is young infants less than 6 months, the children having chronic morbidity in terms of respiratory disease, neurodisabilities, liver, kidney, or hematological problems, or morbidly obese. These are the only high risk or extremely premature babies. These are the only high-risk situations where your upfront oseltamivir is indicated. Otherwise, even in non-risk category of pediatric patients, you can hold on your oseltamivir. And there is a definite scientific evidence as well as recommendation. If oseltamivir is started earliest in the course, there is curtailment of the duration as well as clinical severity, that is viremia, as well as transmission, or that is all three are well controlled if you start oseltamivir within first 48 hours. This is beyond doubt proven by evidence, but it's not necessary in all the cases, as I said. As the case you have depicted here, this is a typical severe pneumonia child who is admitted with severe hypoxia in ICU, where oseltamivir is to be given irrespective of duration of the symptoms, because giving it in first 48 hours is highly desirable or recommendable, but thereafter to what length of symptoms it can be given cannot be told. And the very task it does is proportionate or to take care of the viremia. And duration of viremia may change with the severity of the disease as well as immune state of a child. So even later in the course, giving oseltamivir is definitely indicated in critical patients as shown in this case.
Thank you. Now, in continuation of this, Dr. Palani, I just wanted to ask you one question. Many times there is a epidemiologically relevant situation saying that outside there are plenty of cases of influenza, and the child is also clinically having systemic symptoms like headache, body ache, muscle pain, and you really feel that this is a case of influenza. So, in this situation, are you justified in starting with oseltamivir in the epidemiological setting and a clinically relevant situation?
Um, Definitely no, sir. So far, I have not started in any of the patients in my clinic so far. And the government of India clearly gives guidelines category A, B, and C. So the category A definitely we doesn't need any oseltamivir as such, because this type of patients which going for the severe type of presentation is not very common. They are very unusual patients. So if you start using right, left, and center, then as Bakul sir told, it may lead to resistance and useless of the drug.
Okay, thank you. Now, as Dr. Bakul, you were speaking about otitis media. I would like to know your, information, inputs about viral otitis media. We know that, viruses are responsible for almost 70% of cases, and bacteria and viruses together 66% because they are seen together. So there are also clinical associations with influenza, RSV, and the human metapneumoviruses. And we know that the viruses may impair the response in the mixed acute otitis media. And just wanted to know as to how you tackle with a case of otitis media, in a small little child who is under the age of 2 years and who is under the age of above the age of 2 years.
Yeah, so there are clear-cut guidelines about treating acute otitis media. As you rightly said, 70% of the time it is virus, and other times it is either mixed or directly bacterial infection. So, like what Palniraman said, any child who is below the age of 6 months or maybe the younger age, and child comes with fever and excessive crying with coryza, we have to do otoscopy and diagnose otitis media before there is any discharge from the ear. Otherwise, it's too late. And there, below the age of 2 years, is our guideline says that if child is toxic and has real discharge, we have to start with antibiotics. First line antibiotic will be, of course, amoxicillin. But above the age of 2 years, if it is bilateral severe, then only you will start antibiotic. If it is unilateral, maybe you can wait for some time if child is not toxic and child is otherwise comfortable. And then looking at the behavior of other on follow-up, you can counsel the parents well by giving just paracetamol and maybe some antihistaminic and nose drops and call them back after 2 days and see if there is response. You can always very well avoid giving antibiotics. But if if the clinical condition worsens or if there is bilateral discharge, of course, above the age of 2 years, you have to give antibiotics. Any case, if it is a viral infection, there is no treatment. And there are some clinical clues, as was said, if there is conjunctivitis along with otitis media or pharyngitis, you know that it is more likely to be adenovirus. But you cannot be very rest assured in a case of otitis media that this is virus and you cannot be so dogmatic. So you have to follow the guidelines properly. If younger the age group, severe infection, child is toxic, start antibiotics. If above the age of 2 years, child is playful, not really toxic and no severe infection, unilateral discharge, you may wait. Or if there is bilateral discharge, you have to start antibiotics.
Dr. Palani, I would rather request you to enthuse our listeners for the use of otoscopy, because I know you have also been telling about the use of good quality otoscopes and all. So your experience of using an otoscope in the OPD, because many of our colleagues out of busy practice or whatever reason or the other, they usually do not do otoscopy so routinely. So please tell your experience about using the otoscope in your OPD practice.
And before going that, I will try to emphasize the point Bakul sir told. Pneumonic consolidation, you won't differentiate viral or bacterial, you start antibiotics. In the same way, for otitis media, you don't differentiate viral or bacterial otitis media, you start antibiotic, particularly in less than 2 years. This is the strong statement given by all the academy, except with exceptions. And coming to the otitis thing, and in office practice, no day is passed without a baby with incessant cry, number one. And the baby comes with the setting, that is a fever, URI, and incessant cry. It is a clear-cut setting that you are expecting otitis media, but without otoscope, you can't diagnose, number two. And number three, if the fever is getting prolonged during the influenza season or RSV season, the infection can be there sitting in the mainly the ears. This is the third setting. Sometimes, rarely in fever without focus also, there can be occult otitis media. That is another thing. So these are the four settings you should definitely do otoscope. Incessant cry, fever with incessant cry, prolonged URI, a prolonged fever in a URI, and a fever without focus. These are the four settings. And mostly in a little older babies, you will be successful in examining the ear. But small babies, around 60 to 70% is the success rate, but still it is worthwhile. Worthwhile definitely, because when you start doing regularly, it becomes a very easy maneuver and easily you can see the thing otoscope. When you start familiarized with the normal membrane, naturally you'll easily pick up the bulging membrane. It's a really clear-cut bulging membrane. And nowadays you come across plenty of bullous otitis media. It clearly gives a diagnosis is a pneumococcus. Pneumococcus is the commonest cause of bullous otitis media in a very younger individual. In an older individual, it can be mycoplasma. So like that, it clearly gives a diagnosis on the face. So it's a really very useful instrument. And I definitely urge the practitioners to buy a good macro view otoscope, not the regular otoscope, because in children, it's very difficult to see. First of all, with the regular otoscope, it is very difficult to see unless you have a macro view otoscope.
And one more thing I like to add here with Dr. Palniraman, that indirectly, if a child doesn't allow you to put your otoscope, especially early infancy, you know that mostly you are dealing with otitis media.
Sure.
Pramod sir, may I add something?
Please.
Basically, if we look at the various guidelines across the globe over last few decades, they are evolving continuously. And if we reanalyze them, we are more towards going towards conservative management of all infection. So, like previous days, decade ago, WHO criteria to treat pneumonia, again with otitis media as in guidelines, I will better wait for 2 to 3 days in a non-severe case for spontaneous resolution. And maybe that's the typical case for deferred antibiotic prescription, a very good way of antimicrobial stewardship. If the child cannot get back to you with red flag sign or is inaccessible or staying at remote place, you can write a prescription of antibiotic which may be started after 48 hours of non-resolution in non-severe case. So otitis media, I feel we need to change our approach again because these high-risk categories, the criteria are day by day coming down and they are being pruned down every update of the guidelines. So let us do it proactively. Wait for 2 to 3 days in non-severe cases.
Yes.
So every otitis media need not be, even if bacterial, need not get complication, need not be severe, need not be progressive. Many of the bacterial otitis media, bacterial pneumonia also will have spontaneous resolution without antibiotic therapy. So in non-severe cases, waiting for 48 hours, giving a deferred antibiotic prescription is also a prudent way now to think about giving antibiotics in such kids, which very much is within our purview of practice, especially the access to our patient and our clarity in telling them about the red flag sign or non-resolution or progression. That is quite doable, and I will urge everybody to do that. That is quite doable.
Yes.
Pramod sir, just
Thank
one
you.
point.
Yes.
Yeah. I think very valid points by the experts on the use of otoscope. Looking at it from the parent's perspective, see that if you're seeing the child day 3, day 4, fever not subsiding, you're strongly convinced it's a virus, using your resources to examine the child, spending time examining the ear with the otoscope reinforces the trust the parent has in you. Rather than you just using an antibiotic as a recourse and then not taking enough time to examine. The parent trusts you much more when you examine the child completely and then stick to the same treatment as opposed to doing a very quick judgment without looking at the child completely. And this is not just for that visit. The next time the child is sick, probably they won't come back to you if you do not examine them completely and properly.
Right. Thank you, Sri Krishna. I would also like you to continue with telling us some information about viral pharyngitis. We all know that viruses are the most common cause of acute pharyngitis, and almost 70% cases of pharyngitis are viral. Remaining 30% are bacterial, of which group A beta hemolytic streptococcus is one of the organisms. What is your experience about the viral pharyngitis in your practice?
Yeah, I think it's a common misunderstanding that once it is involving the pharynx, it has to be bacteria. It definitely is not. We have a lot of viruses, EBV, CMV, HSV, adeno, influenza, all these cause viral pharyngitis. And they often leave you with other clues. The other clues include associated conjunctivitis, associated hoarseness of voice, stomatitis, ulcers. Whenever you see ulcers, please think of virus first. Often this will come middle in the course of the disease and the child presents with severe pain. And that pain, please do not mistake it to be a big pus or something sinister going on. It might still be a simple virus. Next slide, sir. You have a couple of very good slides on herpes angina. Yes. So whenever you see a throat like this, and very clearly that there are ulcers demarcated with no tonsillar enlargement, no follicular tonsillitis, and on examination there's no cervical lymphadenopathy, please have a strong suspicion of herpangina and viral as the cause of it. Herpes simplex, next slide, has very simple oral lesions as well. Please look up for it. And once you find the ulcer, most often it might be a virus which is causing the ulcer rather than a bacteria. And continuing on this, the adenovirus.
Yes.
Next slide, sir.
Yeah. This is related to viral conjunctivitis, to which we will come back. Yeah,
Yeah.
you can tell if you want something about adenovirus.
That's all from my end on this, sir.
Okay, thank you. Yeah, that's fine. Now, Dr. Bakul, I just, in the continuation of what Dr. Sri Krishna said, wanted to ask you, many of our colleagues in practice, they want some pretext to start some antibiotics. So they say, oh, your child has throat pain. Oh, your child has difficulty in swallowing. Oh, your child's throat is looking red. Okay, so what is your opinion as to, scientifically, which are the, children where you would suspect bacterial pharyngitis? We have already seen viral, but then are there any guidelines for diagnosing or suspecting bacterial pharyngitis?
The most important point here to differentiate will be that there will be localized infection when there is bacterial infection, and in viral infection you will get coryza, maybe conjunctiva along with pharyngitis rather than anything else. Of course, you'll have malaise and everything. But in infection like streptococcus tonsillitis, you will get follicular tonsillitis. Maybe you'll not be able to swallow the food or water. There will be definitely painful deglutination, and there will be cervical lymph nodes, which are also painful and tender. But most important thing will be to do a localized infection rather than a generalized infection. That will help me in diagnosing this and then start antibiotics.
Yes, Palani, you want to add anything? Yeah.
Yeah, as Dr. Krishna told, when there is ulcerative pharyngitis, no doubt at all. So clear-cut diagnosis is viral. No, don't give antibiotics whenever there is ulcerative pharyngitis. Number two, only when there is exudative pharyngitis or blotchy red, hot red, or erythematous pharyngitis, you come into comes the confusion whether I am dealing with a viral pharyngitis or a bacterial pharyngitis. There comes in handy the modified Centa criteria. If the modified Centa criteria is 4 or 5, no doubt you start the antibiotic. If the modified Centa criteria 1 or 2, no antibiotic. Only when it is between 3 and 4 or 2 and 3, when there is a confusion, you can ask them to come after 48 to 72 hours and you can see, reassess and start antibiotic or not. Because in the corporates and centers, you can do the rapid antigen test when there is confusion. But in the case of periphery, you can ask them to come after 48 hours, reassess and decide about the antibiotic. Pramod, you can throw some light.
And
Pramod Kulkarni, you can throw some light on this. Mainly streptococcal rat test.
Yes, I fully agree with Palni. You said it. The modified center criteria score or MACISAC score is highly reliable clinical tool. And let me little elaborate the 4 points on which the scores are given. Number 1, presence of fever. Number 2, absence of cough. Number 3, tender jugulodigastric lymph nodes. And number 4, exudates or swelling on the tonsil. And as you rightly said, fiery red tonsils, I will advise you to use the LED white light which is available, not the standard yellow light under which everything looks red. If you use the bluish white light, snow white light, you will appreciate what is pink and what is red. And only fiery red deserves some respect. And using center criteria is a standard recommendation about the antigen test. If it is available, if the parents can afford it, you can very well try, as Palni said, for the middle scores of 3, 2, 3 or 4. In that case, you might use it, or you can opt for treating with amoxicillin of 10 days. Either of it, if it is available, it is a reasonably reliable test. If available, one can use that.
Sure. Dr. Sri Krishna, will you like to elaborate a bit on viral conjunctivitis?
Yeah, so viral conjunctivitis, most of them are typically adenovirus. They are associated with upper respiratory infection. Another important point, they are often self-limited. They have a very slow course. They have improvement only after 4 or 5 days. the total duration is up to 2 to 3 weeks. But for the parent, it is a big shock. Every day morning, he sees the child with the big red eyes, the sticky eyes. So he is often confused whether you're going in the right path. Please take time out and tell them all the details on the course of the disease. The child can also present with irritation, a sense of foreign body feeling inside the eye, excessive tears, discharge could be mucoid, there could be crusting as well. Follicles could be seen on the tarsal conjunctiva. The pre-auricular lymph nodes could also be tender, and this is highly contagious. Often, viral conjunctivitis presentation is that one of the siblings or the parent already had it and now has come back with another child having the viral conjunctivitis.
Thank you. Now, Dr. Pramod, I would like you to answer one of the questions which I always have at the back of mind as to why this adenovirus has become a bad adenovirus. Because we never discussed adenovirus to such an extent when we were residents or maybe, a few years back. But now, over say last 1 or 2 years, we have been discussing about this adenovirus. So, what is your personal thought as to why suddenly it has come into limelight and why it is behaving in a different way? Is there any scientific reason or your experience?
Yes, so the things are that basically all these infections were prevalent in past as well, but we didn't know about, we didn't have the diagnostic facilities. Nowadays, we have got good diagnostics to isolate. We have become more aware. And thirdly, with the cyclical changes in the viral circulation, different viral circulation, the epidemiological changes also have made these infections prominent. With the advent of the advanced diagnostics, now we are looking for something more beyond what we can diagnose and which is not responding. And that's why we are picking up more cases, as well as from the surveillance we are getting the current circulation of viruses, epidemic or outbreaks in the geographical region, states or countries as well. So this increased awareness, increased diagnostics, reliable diagnostics have made the change. And definitely there is increase in the circulation because of the various things. There are no more barriers, continental barriers or country barriers now. Infection in one end of globe can go to second end of globe within a day. That is what we have seen. World has become a single global village, and that's why we are aware of it. Nothing else. We never thought of influenza, Dr. Zog, when we were youngsters. But now we know very well it is very much there. It was very much there. And after the pandemic of 2009, now we have influenza in our mind. Likewise, it is all culminating into the increased diagnosis of these unusual infections, like in adenovirus. So it's not a new virus. It's not bad virus. It's the same virus. Very rarely, in very few cases, the antigenic shift or drifts or changes might add to change in the behavior of the disease, but which has to be substantiated by the surveillance system as well as the NIV. Then and then it can be backed.
Thank you. Thank you for that elaborate answer. We have almost covered all the upper respiratory infections, and now we'll go to the lower respiratory infections. Today, we are trying to keep away from the common infections, viral like dengue and others, because they are often discussed in other, on other fora. So first, we will discuss about this croup. And Dr. Bakul, would you just like to tell something about this particular condition, which is laryngotracheobronchitis, and your experience?
Basically, it is one of the very common scenario which we get for indoor patients. But at times they come with change of voice and mild croup where there is not child is not really uncomfortable or not really breathless, but there is change of voice and maybe stridor at when child cries or something like that, and they come. So here we don't have to worry. Most of the time it is viral, as it is mentioned here, is RSV or influenza, and occurs in younger age group, and they usually recover on his own like any other viral infection by day 7. And we have to just comfort the child by giving some good hydration and maybe anti-anxiety type of maneuvers, like child should be made to sleep in a child where it's is feeling comfortable rather than disturbing the child too much. And at times when things are not improving, you may give a single dose of steroid, or maybe you can give nebulizer with budesonide, it helps. But if it worsens or if it is moderate to severe, where there is stridor at rest, child is really breathless, becoming hypoxic, then of course you have to admit and give. Uh, First thing is you avoid looking at the throat, because that can stimulate bronchospasm and cause problem. So you have to make the child sleep in a comfortable position and give them supportive laminar treatment with, most importantly, nebulization, either epinephrine or salbutamol, maybe one dose, one time. And if child shows improvement, then you continue. If not, then you can avoid. Nowadays, we are also using 3% saline if they don't respond to epinephrine or salbutamol. But this is a very common condition, and based on whether it's mild, moderate, or severe, our treatment varies from nothing to maybe admission, nebulization, and sometimes antiviral drugs.
Now, thank you, Bakul, for that. Now, Dr. Panni, I have one small question. We all know that croup is usually viral, but then have you ever seen any bacterial infections producing stridor, like say diphtheria or epiglottitis in your practice, or you have always been happy with giving the treatment with single dose of dexamethasone or nebulized epinephrine? So, what is your experience about these cases?
With respect to complicated croup, so far, because epiglottitis is not common, first of all, it's not common, and secondly, because of the very good Hib immunization by our government of India, now, like meningitis, it cannot be thought of itself. So epiglottitis is out. Number two, I had seen in the over the 30 years, one case of bacterial tracheitis following a croup, following a viral croup in an older child, and child suddenly becoming bad and becoming toxic along with the croup, along with the distress, and finally turned out to be a case of bacterial tracheitis. That's a complication of the croup. Those things occur very rarely, not a common thing.
Okay, thank you. And Dr. Pramod, I would just like you to elaborate a bit about your experience about bronchiolitis, particularly related to RSV. Why I'm asking you this question is that all of us, as the elite listeners in the audience, we all know as to how to diagnose bronchiolitis and the therapy. We know that right from our residency days, we have been told that it's only the hydration and oxygen which is required, and no routine bronchodilators are required. That's known to us. But somehow what I have seen is over last year, the discussion about this RSV related diseases has suddenly increased. Maybe people are hearing about the vaccine or nirsevimab, or maybe whatever is the reason. What is your candid opinion about incidence of bronchiolitis, crude bronchiolitis related to RSV, and need for the vaccines or the monoclonal antibodies? So, what is your opinion?
Basically, we all see so many cases of bronchiolitis. It's a clinical diagnosis, and none of us can fail on that, will fail on that. It's almost diagnosed by everybody, even the novice in pediatric, even the new residents also. The only things which go wrong is while treating, especially when we hospitalize these kids. There is a self-inflicted pressure to treat a child who is admitted with something. But again, the principles and the science says there is no need of any of the measures except supportive measures, that is hydration and oxygenation. There is no scientific evidence to any of the so many variety of interventions, pharmaceutical intervention, pharmacological interventions, which have been tried over decades now. None of them is supported by evidence, and none of them have stood the test of time. About the bronchodilators, that is the most abused indication in bronchiolitis. We all use bronchodilators, and that is totally irrational. None of the bronchodilators, because bronchodilators work only in reversible bronchospasm and bronchiolitis. We know it is the bronchiolar edema and obstruction which is the cause, not the contraction of the soft muscles in the bronchi. So this has to be kept in mind, the basic fact. And the treatment again remains symptomatic. You have to be very patient because bronchiolitis again is a illness which takes weeks to get better, worsens by 4 to 7 days. Especially in young babies, it can take 2 weeks to get well, to get back to normal. This has to be kept in mind. And about the prevention, what you said is the infection control measures. Prevention is the most important, especially in the hospitals. Very important. We never cohort our patients of bronchiolitis, and we expose our high risk patient also admitted under the same roof to RSV, which is highly contagious disease, which is spread by contact as well as by respiratory droplet. About the preventive chemo prevention, about the monoclonal antibodies, it's a standard practice. Palivizumab has been established therapy for high-risk patient, which is being practiced in the West regularly. But the problems were there every month to be given before the season of RSV circulation and all those things. Here in India, it is not practical. Nirsevimab is a golden improvement. Only one dose to be given before and highly effective for high risk. In India, there is no current recommendation for all these because these are not at all cost effective. One single dose of nirsevimab costs about 58,000 rupees. And even if we have people who can afford it here, it's not recommendable right now. The other infection control measures are definitely recommendable across India. There is still time to go for these products to be used routinely in high risk. Of course, in very high risk patients, one can opt, but the availability again is going to be a problem. About RSV vaccine, it's a standard treatment. These vaccines are meant for pregnant mothers in the latter half of pregnancy in the third trimester, and that definitely transfers the maternal antibodies to protect the young infant over first 3 to 6 months, during which the severity of bronchiolitis is very high, and morbidity as well as the occasional mortality. So definitely RSV vaccines are being practiced and being recommended in the West. Will come to India sometime or other, and whenever they come, definitely recommended.
Thank you. So, what we learned in our residency days that for bronchiolitis, A, B, C are not to be thought of, like antibiotics, bronchodilators, and corticosteroids. So that continues even today. Now, Dr. Palani, yeah, I am coming to you. You can add your comment along with the answer to my question. The question is, from a practicing pediatrician's view, many times, it becomes difficult to differentiate viral bronchiolitis from viral pneumonia from bacterial pneumonia. Okay. And ultimately, our colleagues, knowing fully well that, it is likely to be viral, but under so many pressures from patients, this, that, and, all the factors that we know, they ultimately end up giving antibiotics and bronchodilators and steroids. So we keep discussing, but then what is your real opinion and how would you rather convince the audience as to antibiotics are really not required, but are there any ways to differentiate these situations from each other? I know it's difficult, but then have you given a thought to this? I'm sure you must have. Thank you. Yeah.
Yeah, very good question. Very good question. A really thought-provoking question. And we know the bronchiolitis among the RSV manifestation. Bronchiolitis is the commonest manifestation. Usually, they are happy baby with wheezes. Happy baby with wheezes, and usually majority are happy babies. You go along with the 3% saline nebulization and reassurance. If at all they are fearing, give the danger signs, counsel them with the danger signs, and comes to them not able to sleep or not able to feed, immediately return back. That is our two thing. Immediately will come, will give the thing. One thing is viral pneumonia. Among the thing, the viral pneumonia is other end of the spectrum. Other end of the spectrum, where the child is having a viral infection, but with mainly the interstitial is involved, and usually the child is sick, and the child will present with the grunt rather than the wheeze. Here, there will be wheeze is predominant, there the grunt is predominant, and definitely you know whether if it is a grunt with the chest drawing with respiratory distress, it has to be admitted. Whether it is a viral pneumonia or a bacterial pneumonia, it has to be admitted. And bacterial pneumonia, you all know naturally it is going to be a sick baby or a toxic baby with a grunt along with the localized finding of crepitations or a bronchial breath sounds or not. But usually wheeze versus grunt that gives the clinical differentiation between the particularly the bronchiolitis and the viral pneumonia. And when you take a chest X-ray, in case of viral bronchiolitis, the hyperinflation is the predominant manifestation, whereas in case of viral pneumonia, it's a dirty lung with the interstitial bilateral streaky shadows will be the manifestation. Whereas in case of pneumonia, you know the patchy, blotchy infiltrates here and there, the bacterial pneumonia. This is the way mostly as you become senior, it is very easy to differentiate all these three. But for a junior, definitely we should definitely make aware viral pneumonia is different from viral bronchiolitis, and it has to be admitted. Viral pneumonia has to be admitted with a good supportive management, and this is the way we can easily go in a office practice.
Thank you very much. And then of course we all know please.
Another one point in the viral bronchiolitis, we know majority will settle over a period of time. Sometime the fever goes on, because even though baby is not sick, the fever goes on. This is the time you are worried whether am I dealing with a secondary infection, and secondary pneumonia is hardly 1%. The child will be sick and you take a chest X-ray, you know the diagnosis. But sometimes the child is not sick, but still the fever is going on. You should always rule out underlying UTI. UTI is also a hidden infection in bronchiolitis, which one has to be taken care of. So always, whenever the fever goes on in a bronchiolitis, even though baby is not sick, always try to do a urine examination, rule out UTI, which is around 5% in this sometimes.
Just one point, Dr. Pramod sir.
Please.
Yeah, I think in RSV infections, especially bronchiolitis, you want to do a lot because you see the child tachypnic, but then it's a happy child, as just mentioned. What is most important is oxygen. All your focus is on bronchodilators, nebulization with whatever you have, sometimes even with NAC. Also, parents asking for pavlizumab. It happens at the place where I practice. But then the focus should not shift away from humidified oxygen. And if it is a severe case, HFNC. These work like magic. The child automatically will get better. It's just a matter of time. You just have to trust where is the problem. It is the edema and the child being tachypnic, and a very good improvement with just two things: IV fluids and humidified oxygen. Just stick to this and most of them get better.
Okay. And then what is your opinion about this 3% saline being used in the nebulized form? Any experience with that?
Evidence supports in case of moderate and severe cases. I think overall it comes into the picture of the overall basket of interventions that we have. But as I said, doesn't take away the role of HFNC and humidified oxygen. One-time salbutamol or epinephrine trial can be tried in case of severe bronchiolitis, but humidified oxygen and IV fluids, they continue to be the mainstay.
Okay, thank you. Now, Dr. Bakul, viral gastroenteritis has been there for ages now, and everybody is aware of the zodiac management, that is the zinc, ORS, and the diet, which includes continuation of breastfeeding and instructions, and then avoidance of antibiotics as far as possible, and then the common sense and cleanliness. So that particular management goes without saying. Now, just tell me your own experience as to where you would think of giving antibiotics. We all know that watery diarrhea is viral. We all know that onset with vomiting, and then within 24 hours when diarrhea begins, it is rotavirus, and we have already started witnessing it as the winter has started in this part of our country. What are your views about antibiotics as to when do you feel that I should intervene and give antibiotics?
Again, there are some clear-cut guidelines given by IAP and which I am following very strictly in my practice. 99% of the time, I don't require any antibiotic or combinations of ofloxacin and so many other combinations of flagyl, metronidazole, absolutely useless. Antibiotics properly are required only when there is bloody dysentery, one. If there is cholera, two. And if there is loose motions occurring in a immunocompromised child or a malnourished child, then only I'll think of giving an antibiotic. And again, when you give one course of antibiotic with proper dosage, if it doesn't respond, try second antibiotic, it doesn't respond, then only I'll add metronidazole, not otherwise, because amoebic dysentery is again very rare. But 99% of the time it is ORS, zinc, and proper diet.
why I ask you this question is because are there any conditions where there is, watery diarrhea, but the etiology is bacterial?
So,
So,
diarrhea, only etiology, bacterial etiology can be cholera, nothing else. So, unless and until you know
okay.
for very sure that child is coming from an epidemic area or you have confirmed diagnosis of cholera, I don't think we should give antibiotic. Anything watery is usually viral.
Enterotoxigenic E. coli, ETC is traveler's diarrhea is common bacterial watery diarrhea, but again, it
Doesn't require
doesn't need
antibiotic.
antibiotics at all.
Doesn't
It
require
is toxin mediated, doesn't require antibiotics.
Okay, and Pramod, in the continuation of the same, we sometimes hear about this cryptosporidium as a cause of diarrhea. What is the type of diarrhea, and what is your opinion about this organism? Because some of the studies which was labeled as GEM study, global enteric study.
Yes,
So there, cryptosporidium was supposed to be high on the list following rota. So, what is your opinion about this?
definitely it is one of the 5 prominent uh, pathogen identified in diarrhea. And cryptosporidium is a common parasite. It's a protozoan, but it's not a problem at all. It is only problematic most of the times in immunocompetent patient. It is a self-restricted acute watery diarrhea, doesn't pose any threat. Only immunocompromised or immunosuppressed patient, especially in HIV, it can cause a serious disease where the treatment with nitazoxanide is indicated. But otherwise, there is no role of treating presumed cryptosporidia with nitazoxanide or any other agent. For us, cryptosporidium is a pathogen, though common, not to be treated on a routine basis.
Thank you. And then Dr. Palani, again, as a promoter of rational antibiotic therapy, in your so many years of practice, what are your experience, I might say, in treatment of viral gastroenteritis, and how often do you need to, give antibiotics? Because we always say 90% of diarrheas are viral. That's fine. But then, what is your own experience in this field?
Yeah, it goes with the guidelines. It goes with the standard saying that nothing is going to work except your mainly diet and hydration. Mainly diet, nutrition, and the hydration part is the main part, and the ORS, and even the zinc. And the zinc will be maybe helpful in a malnourished child. Otherwise, zinc is also not a very thing. It won't stop the diarrhea. It's not going to think. Usually, when the patient comes, initially we start zinc. After 3 days, if they come, they will start a probiotic. So we see to that the time is going for 3 to 5 days, 5 to 6 days. By the time diarrhea stops, so only thing is, so you either you start probiotic followed by zinc, or zinc followed by probiotic. Only the oral counseling matters more than any other thing. Only the diet, hydration, and ORS. That is the most important thing. And what to give, what not to give. Particularly, people contain glucose-containing fluids, and so have mainly the that is hydrated drinks, hydrogenated drinks like cool drinks, or any mainly fruit juices, which are the things which should not be given during diarrhea, which has to be again reinforced. Plenty of people doesn't know this thing. These are also fluids which will help the baby, but this will actually harm by producing osmotic diarrhea.
And most important thing will be counseling. Counseling is very, very important because a number of motions, if they are increased, then parents they get upset and they directly go to the medical store and buy antibiotics. So counseling is very important sentence is that it's a protective mechanism. Body is trying to throw away the dirt and the toxins, and that will help you. And I think parents will stick to you if you counsel them well.
Sure. And then Dr. Sri Krishna, we are coming to the last condition which we are going to discuss today, and that is the hand, foot, mouth disease, and your views about this.
Yeah, HFMD, we've all faced it across the country. Probably it came like the rain and it lasted as long as the rains did, and it ensured everyone got it. Caused primarily by Coxsackie, enterovirus as well, very common in the preschool age group. Very, very mild fever, almost none. But the rash is very prominent. It typically falls into the distribution of hand, foot, mouth, could also start in the buttocks. And this rash is very scary rash. The parent has to look at the rash the whole day, but then it lasts for up to 1 week, and there is hardly anything that needs to be done. In the OP, we have been telling parents, this is like the rain. Can you stop rain? You can't. You can't even stop the HFMD. But what do you do about it? You just wait it out. So this is the typical distribution of the HFMD rash. It is self-limiting, hardly any complications if you are able to ensure hydration of the child. The problem is not the rashes on the hands or the feet, but the ones in the mouth. It's the oral ulcers that immediately cause the child to stop feeding. So ensure that you are able to give symptomatic treatment and good hydration. Most of these would recover. Very rarely would they end up in any form of complication. This has been our experience as well, and the same is there from guidelines. Reassurance, reassurance. Let the child keep coming back to you, perhaps after 1 week, even after 10 days. And please counsel them that this is something that will stay. You will keep looking at the rash, but there's not really any trouble the rash does to the child. The parent is more worried than even the child. So treat the parent if you want, but not the child.
Sure. That's that's an important thing. Now, I just wanted to ask Dr. Palani, Dr. Pramod, and Dr. Bakul also whether they have really come across any complication of this HFMD, like this septic meningitis, encephalitis, myocarditis, and in case if you really have not come across, you can always tell us. But then, have you come across any complicated cases of HFMD? Dr. Pramod
Honestly, no
Kulkarni.
case in my practice, definitely no.
Okay. Dr. Pramod, have you come across any complicated case? Being an ID specialist, maybe.
Not truly. Only those having severe oral lesion requiring IV support and brief hospitalization. Nothing beyond that.
Okay. And Dr. Palani, do you have any other
Yeah,
experience
in
about this?
the past 3 months, I had around 200 cases of HFMD, believe it or not. And now, as previously it was found to be mainly preschoolers and very younger age group, now it is extending to the school going age. That is one phenomena. And usually we counsel by giving the natural history of the disease. By it is it is a playful exanthem, and by another 3 to 4 days it will darken and it will scab out. When you tell them, and they see it is getting darkening and scabbing out and it is completely drying out, and naturally they will feel happy what you have told, it is coming happening. So that is the way we usually counsel the patient, and no complications as so far.
Dr. Pramod
Okay,
said
thank
just
you very
one point.
Yeah.
At Hyderabad, we have
Please.
seen nail changes happening post HFMD, and we did some research on it. Apparently, there are some nail changes that happen, Bue's lines and the thinning out of the plate, onychomatosis. So these are some changes, and we've had it in 2 patients. Interestingly, the parents came up with the diagnosis and came back for a follow-up. This can happen anytime, 1 to 3 months after the HFMD.
Okay, it's very good. Anyway, with all this, we have covered a lot many points in the viral infections in children. I am aware that we have kept ourselves away from dengue, chikungunya, measles, chickenpox because they are discussed on different fora. And I'm sure our listeners must have been benefited by the experiences and the comments from all our esteemed panelists. And I always feel that we have to continue being rational, and during this journey many times we may have some experiences, we may commit some mistakes, or there could be some pitfalls also. We may sometimes fall in those pits, and then we have to get up and continue our journey. And with this, I expect that everyone has a very, very happy journey on this particular journey of rational management of children. So thank you, PIDA group, for involving all of us in today's discussion. And I hand over the proceedings to our colleagues, Dr. Manish and Dr. Chetan. Thank you.
Yes. Yeah. Thank you very much, sir. Sir, yeah. Thank you. So it was an excellent session, sir, because I think after today's session, many would be jittery while writing the antibodies tomorrow in case of some viral URI or viral diarrhea patients. Definitely, it will help them. There are a few questions in the chat box. First, I request Dr. Jalil Ahmed, sir. He has put few questions, sir. You can directly ask the question, sir. Dr. Jalil, sir.
Sir, only thing is when we should involve in case of there is a peculiar character of this adenovirus, which sometimes unexpected progression is there. What is the core factor operating in adenovirus causing this sudden progression?
Both Kulkarni, will you like to take it up?
See, adenovirus is distinct and well known for the high degree of inflammation it causes. That's the reason it has a prolonged or protracted course. Rather than a very rapid torrential course, it has a prolonged course. And it really doesn't, there is hardly any indication to tell you about when to involve ID experts. It's finally remains the clinical management of supportive treatment only. There is hardly any specific treatment in that. Adenovirus is well known for its high degree of pathogenicity, cytopathy, as well as the inflammation it causes.
I had,
That,
Pramod, I will like to add something. I had been to Kolkata 2 years back, and there was a adenovirus epidemic going on there, and people were treating their patients with cidofovir at times with good results, and most of them felt that adenovirus led to prolonged bronchiolitis and ultimately linked to bronchiolitis obliterans and complications like that. So that's why they were forced to give drugs like cidofovir, which otherwise is very toxic, nephrotoxic, and there is some other compound, sister compound of cidofovir, they were using it. But adenovirus, if it lasts longer, definitely it can cause complications and can be treated with drugs like this, as per my Kolkata colleagues, what they said.
Pramod sir, just one point, if I may.
Please.
Yeah, just to add to this, I
Please.
think it's probably down to the cytokine storm. The cytokine storm, more research is needed before we can label this as the main cause, but that could explain the lab findings, could also explain the sudden worsening that happens, and also the improvement with a strong anti-inflammatory approach. So probably it's the cytokine storm to blame.
Since we are seeing severe form of adenovirus, when should we involve ID specialists?
When it is not behaving as expected.
Because we are finding difficult by
Yeah,
seeing the
so when it is
static
not behaving as
progression of the
expected, you
disease
are likely
in
to
the
get
PICU,
complications.
and will the ID specialist will be able to guide us properly?
Hopefully.
Okay. And is there any cross protection with this Castelmine for the adenovirus
No,
when
no,
we
there is no
prescribe
cross
for
protection.
H1N1?
No cross protection.
Thank you, sir.
Yeah.
And
So there,
I like to little beg differ with Sri Krishna. Not only cytokine storm thing, because of the outpatient patients, which plenty of adenovirus patient epidemic last year we had in February and March, and majority of the patients were stable, but still they were having a neutrophilia and high CRP. So I think something extra, something is happening that with respect to, they are little invasive, I think.
Anybody correlated the adenovirus usually produce severe conjunctivitis. Now it is predicted towards the lungs. What could it be? Is it a special mutation of the same virus?
And unilateral
sir,
conjunctivitis.
there are different strains or serotypes of adenovirus. Each has got different pathogenicity. If you recollect, there are different adenoviruses causing diarrheal diseases. There are different adenoviruses causing conjunctivitis. There are different adenoviruses causing pneumonia. So it's not a single virus causing everything all. So about the conjunctivitis, the epidemic keratoconjunctivitis is very specifically caused by one particular strain of adenovirus. And you can get conjunctivitis in the adenoviral infection causing pneumonia or respiratory syndrome. Both are a different one. So each type of adenovirus has got different pathogenicity and tissue affliction. So you can get particular organs involved with different severity, with different types. It's not that one adenovirus is causing everything. There are different serotypes having different tissue affinity
One
and
final
severity as well.
question: what's the role of biological in severe adenovirus?
Sir, let me tell you, all these are experimental things. There is no evidence-based recommendation for any intervention. Even what Bakul Bhai said, what they have tried in Kolkata and all those things are just trial and errors. What we did in COVID, There is no evidence to support all these things. So I will personally tell, involve a ID specialist, and 1 in 1,000 scenarios you can be put to the corner to use these things only with advice of an ID consultant. So for general practitioner, general pediatrician, it's not a question to think about at all, about antivirus at all.
So when you want to share the responsibility, you refer them to the ID specialist.
Yeah,
Sir,
maybe Dr. Manish, I
yeah,
just thought, yeah, in
yeah,
the
there are
heart
few
of my heart, I
questions in.
thought,
Yeah.
yeah, just wanted Dr. Balasubramaniam, whom I can see in the panelists, maybe his views in case
Yes,
if
sir,
he's comfortable,
definitely.
you can just yeah.
Yeah.
Then we can always take other questions also. Yeah.
First view is that it's a fantastic session. Thank you, Pramod, as usual. It is expected. Only thing is, I thought there were fewer jokes than we normally have in your session today for a change. Probably your system was infected with the virus, bringing
No,
the humor down.
probably he's aging
Bringing
now.
down the
He's aging now.
humor part of it. That's one.
Pramod is aging now.
Yeah, a few comments. When that was a very interesting discussion on adenovirus. See, you must remember adenovirus has been there quite for some time. And we do not know why we are seeing more severe cases, more number of cases now. It might be because of, it is like serotype replacement of pneumococcus. The viruses are, which were there are being replaced with new viruses, more virulent viruses. And coming to the doctor, that was a very interesting question from Dr. Jalil. How do you recognize severe adenoviral infection? There is no way you can predict. It's not necessary that those who have high count, those who have high CRP always are going to develop serious adenovirus infection. It's not known to predict the course. Regarding Cidofir and the other drug which is often used is immunoglobulin, IV immunoglobulin. Both, I'm afraid, in immunocompetent patients, there is no role. But Jalil, one thing, if you have a severe adenovirus infection, you must take help from an ID consultant or an immunologist to rule out primary or secondary immunodeficiency. That's a must. If the adenovirus is misbehaving in a host, you have to look at some underlying problem in the host. Not that every severe adenovirus pneumonia is due to immunodeficiency, can occur in normal children, but at least I have seen adenovirus in an SCID, severe combined immunodeficiency. It can be a manifestation of any immunodeficiency. That's one thing we have to keep in mind. That's one. Second, on the discussion of otitis media, I mean, it is very clearly mentioned by Dr. Sri Krishna that the wait and watch policy is probably the best. Somebody said you have to know the side, whether it is unilateral or bilateral, you have to know the age and you have to know the severity. In fact, in Scandinavian countries, about 2 years, they do not start antibiotic at all. It's always reassess after 48 to 72 hours. So our problem is patient coming back. Our problem is expertise in doing otoscopy. So use these 3 criteria, age, laterality, and severity to decide antibiotics. And Paniraman very rightly said, for a disease like streptococcal tonsillitis or otitis media or sinusitis, you're not doing any crime in delaying the antibiotic therapy initiation by 2, 3, even 4, 5 days. You won't lose the game. You won't lose the child, right? And you don't have to have what you call high target attainment rates for pharyngitis, sinusitis, and otitis media, like meningitis or pneumonia or pyelonephritis. You can wait and watch. You can delay the antibiotic decision. And coming to pharyngitis, because it is very nicely put that all the pharyngitis is not bacterial. In fact, majority of pharyngitis is only viral. Majority. 2 points I wanted to stress, which practitioners often forget. One is, if you have petechiae in the soft palate, is more likely to be bacterial, quite contrary to what we normally think. When we see petechiae, we always think it is viral. But if you see petechiae only in the soft palate, is more likely to be bacterial rather than viral. 1. 2. Other important clue to bacterial pharyngotonsillitis, you have a red tonsil, you have abdominal pain, is more likely to be bacterial than viral. These two important clues, which are often overlooked by us, in addition to Centaur score. And again, Centaur score is not everything. In adenoviral pharyngotonsillitis, our Centaur score can be 4. So it doesn't mean anything. There may not be conjunctivitis. So Centaur score is not everything. You can go wrong. Okay. Because if you ask me, rapid test is simple, you should use it. Last comment on the proof. Throughout the world, there is a movement towards giving steroids even to mild croup. Mild croup. If somebody wants to give dexamethasone single dose even for a clinical diagnosis of mild croup, he or she is not right, because studies have shown it. It reduces progression to severe croup and moderate croup. It helps not only in moderate croup, might help in mild croup. And the other comment is, Dr. Paniraman said bacterial tracheitis, very rare, and it is not caused by H. influenza, it is caused by Staph aureus. So if you have a sick patient with biphasic stridor, high fever, leukocytosis, the antibiotic that you give, ceftriaxone, will not be enough. You have to add vancomycin to cover your Staph aureus. And final comment, oseltamivir, please, I think we must tell our pediatricians, please do not, what Paniraman said, I'm repeating it, please do not use in your OPDs. It has no place. It has no place in outpatient treatment. And oseltamivir can cause serious neuropsychiatric reactions in children. I have seen them, 1 or 2 cases, above 15 kg, above 5 years. It can cause serious psychosis like picture. So it's not recommended. And if you need to use oseltamivir, do not hesitate to use it even for 10 days in severe cases, hospitalized cases, if you have pneumonia. And if at all there is any benefit of oseltamivir, it may bring down the fever duration, maybe by 8 hours, 10 hours. It's not going to prevent complications. It's not going to reduce mortality. Last comment is, nirsevimab is going to revolutionize the management of bronchiolitis. New England Journal, April 2024, nirsevimab, multiple sites, has clearly shown reduced risk of hospitalization, single dose, and I'm sure it will be cost effective, because RSV, which was more common, more severe in the United States, is increasingly becoming more severe, more common in India. So nirsevimab might be the game changer for RSV. I'm sure it will be introduced next year, and it will definitely reduce morbidity in RSV. Initial trial results are fantastic. Thank you very much. Wonderful. I enjoyed it.
Thank you. Thank you very much, sir. Those inputs were very crucial and always very precious for us. Sir, one more thing I wanted to ask
on the bacterial tracheitis. This is always a diagnosis by direct visualization from the pouring of pus from the trachea. That's what in my PICU experience I
have not seen a case myself, but I'm only quoting from textbooks and literature. Yes, directly you will see pus in the trachea. Again, clinical diagnosis, high fever, leukocytosis, polymorphonuclear leukocytosis, biphasic stridor. See, usually in croup, it's not a biphasic stridor. Biphasic means there is some involvement of the trachea. Okay, severe toxic child. I don't think I'm going to do, I will ask my ENT, I will start antibiotics after taking a culture, then call the ENT surgeon for a diagnosis and intubation and life support, whatever. And of course, intensivists like Dr. Sri Krishna. Okay.
Yes, sir. So, sir, there are a few questions from the chat box in the YouTube. Dr. Aryan Sharma is asking, in viral, usually fever doesn't respond to paracetamol. What is the next step, safe choice?
No. It's a myth. Who said viral infections, paracetamol doesn't work? In fact, I'm fond of telling my PGs, prompt deferescence with paracetamol You cannot distinguish viral versus bacterial. Even in meningitis with paracetamol, the fever might come down. Flu, paracetamol might come down. And in both meningitis and flu, paracetamol might not bring down the fever at all. Don't treat the fever numbers, treat the child. What if there is fever? 102 child is playing, I wouldn't worry. On the other hand, 100 child is drowsy, I'll be worried. Don't go by the numbers. Don't worry about the parents' anxiety. You bring down the anxiety of the parents rather than try to bring down the fever. And mefenamic acid, I wouldn't use it at all. I've never used it and I wouldn't use it. I wouldn't recommend it also. If at all you want to use ibuprofen. Even that, I will have to be careful because in India, there's so much of dengue and our parents don't give food when there is fever. And you may end up having acute renal shutdown or a bleed when the child is being starved due to a viral infection. So you have to be careful. Paracetamol, all said and done, even though it might not bring down the fever, it's pretty safe.
Yes, Palniraman sir.
Yeah, actually, Professor Amdekar, even by 2004 itself, he brought the philosophy of comfort therapy versus antibiotic therapy. So the comfort is more important than crashing the temperature down to normal. So the philosophy of comfort therapy has to be told to all the practitioners, and they should counsel the parents that the child's comfort is more important rather than crashing the temperature down to normal.
Comfort to the pediatrician is not at all important.
Even in acute viral infection, the IV paracetamol has got a very good impact and bring down the discomfort.
Why should you use IV paracetamol?
No need.
Why?
Why? It's
Why should you use IV? Why should you use in the Middle East rectal paracetamol? Why?
No
I
need.
don't know. The response is very.
Why do you want to go? What's a big deal? What are you going to achieve by bringing down the fever from 102 to 99? And if the virus is there, it is going to climb to 104, like stock market coming down and going up.
Only if child is continuously convulsive, then you may need to bring down the temperature sometimes.
Even in
unconscious patient,
convulsions cannot be, Manish, there is enough evidence that you cannot prevent febrile seizures by aggressive antipyretic therapy.
No, sir, in status. If child is already in status, then.
Even if it is status, bringing down the fever is not going to make any difference. The status is not because of fever alone, because of so many unidentified factors. There are trials of rectal diclofenac in trying to prevent febrile seizures. They have failed miserably. So fever reduction is not the treatment mantra for febrile seizures. 102, 103, it may not throw fit. 99.5, it may throw fit. It's not in your hands.
Yeah, definitely. Sir, is biphasic fever a sufficiently reliable feature of viral infection, Dr. Swapnil Usgaonkar?
I think biphasic fever, sir, Pramod Jog, I'm sure will be able to give more detail. Biphasic is not always viral. It can be sinusitis. It can be even otitis media following a cold, right? It may be a secondary infection with a primary viral infection, anything. But by and large, if you have 100 biphasic fevers, 90 will be viral.
That too dengue, sir.
Yeah.
Dr. Venkateshwar Rao said that in private practice, CRP is used to start antibiotic as a label of secondary bacterial infection. Your opinion?
No.
It has already been discussed.
No.
Yeah.
Wrong.
CRP can be used to stop antibiotic, not to start antibiotic.
In Dr. Jyoti Prakash, in case of upper respiratory infection, if total count is normal, neutrophils are normal, antibiotics need to be started or not?
If you have clear-cut evidence, if you have clear-cut otoscopic evidence, because if there is otitis media, because if there is a localized infection, your CBC and CRP is going to be normal. Only you have to go by clinically and otoscopy wise, you have to start the antibiotic. You no need to go for the CBC or CRP when you are having suspecting these things, clinical things.
Pandiraman, why do CBC and CRP for URI? It is
no
not
need.
CRP. No, it is not CRP. It is not clinically relevant practice.
Sir, Dr. Palani, one more thing. In CBC, how this monocyte influences towards viral versus the bacteria? Monocyte.
Not much, sir. Not much.
Not much. Okay.
Is there any evidence for hypertonic saline nap for bronchiolitis?
One-time trial, if shows response, continue, otherwise stop.
Probiotics.
Actually, the studies tell that a marginal benefit of few hours less than a day of resolution. So it really doesn't deserve any respect.
Sir, I think the hypertonic saline neb, it works because it takes the edema. So the problem in bronchiolitis is the edema. So it takes the edema, but then AAP have a very clear recommendation of no benefit. Nice guidelines from UK, no benefit. And the evidence so far does not promote use of nebulization as a management principle. It continues to be humidified oxygen and hydration.
Actually, Dr. Sri Krishna, if you go through literature on bronchiolitis, in fact, I'm going through literature on bronchiolitis from 1980 onwards. Every 4 years, okay, there will be one trial saying steroids are useful. The next 4 years, a trial will come and tell you it's useless. And that has happened for bronchodilators. It has happened for adrenaline. It has happened for salbutamol. It has happened for 3% saline. It has happened for dexamethasone. It has happened for budesonide. And now everybody agrees.
You try to use it and find the see the
do
thing.
nothing except give oxygen, as you nicely put it. The only thing is, in fact, I remember still the 9th edition of Nelson, which I read when I was an MD student. I'm quoting exactly. 3 things were mentioned in the 9th edition. Of course, it may not hold good today, but for historical purpose, I'm just mentioning that. 1, if an infant who has bronchiolitis has eosinophilia, 1. 2, if on auscultation, if an infant with bronchiolitis has got a prolonged expiration and a marked expiratory wheeze. 3, if there is a family history of asthma or severe atopy. 3 factors. If any of this is present, that infant with bronchiolitis is more likely to respond to bronchodilators. I am sure none of you would disagree what was quoted in 9th edition and which is no more found in books. None of you would disagree. Am I right, Dr. Pramod? With what I said? Yeah. 3
Yes,
points.
sir.
3 points. Other than this, and later, some books mention you give a trial of bronchodilators. If it improves, you give salbutamol.
Yes.
How do you give a trial? You give oxygen and you give salbutamol. Child will definitely improve symptomatically. And you will say salbutamol is working. So it's very subjective. Very subjective.
Yes, sir. And sir, anything about probiotics in acute watery diarrhea?
No
Any
use.
1 or 2 words?
See,
No use.
0. Someone has asked, azithromycin has immunomodulatory effect on eosinophilic inflammation. Any
Avoid.
anti-inflammatory property, can it be used in persistent cough?
No.
Azithromycin deficiency is not the cause for persistent cough. That's my answer.
A word on Clostridium difficile diarrhea.
That was already discussed, huh?
Yes. How to differentiate flu from other viral fevers? Most of times children are fever. There is no need to differentiate, right? And in babies less than 3 months and Shigella antibodies indicated.
What is the question? Repeat the question.
In babies less than 3 months and Shigella antibodies indicated.
Less than 3 months, naturally, you are going to give antibiotic in a diarrhea because naturally they are systemic infections and you will be very careful. It's not an easy thing. We have to be very judgmental in those cases. It's a very tricky thing. Less than 3 months treating the babies with diarrhea, whether healthy baby, sick baby, and many factors play into role.
And someone has role of acyltamivir in bronchiolitis in flu season.
No.
No. So one more thing I wanted to ask. We are giving dexamethasone 0.6 milligram per kilogram in croup. If you want to give it on OPD base, like oral preparation tablet is 0.5 milligram. If a 10 kilo child is there, you need to give 6 milligram. Then how do you give, sir?
Dexamethasone is available as 4 milligram tablets. 4 milligram tablets are available. One company has come out with 4 milligram tablets. It's available. I forgot the trade name. I think it is Dexona. if I remember correct. Paniraman might remember.
No, sir. No, I don't.
4 milligram tablets are available in the market.
But little less.
When I asked, it was only 0.5 milligram. So can we use
Practically,
like
prednisolone is equally
prednisolone?
useful. There is hardly
yeah.
anything to differentiate between various types of steroids. Prednisolone
Prednisolone
is
is
well
better.
acceptable, no problem.
Pramod, there is a technical point. Your necessity to use dexamethasone and croup is there because dexamethasone, unlike prednisolone, has got a very long half-life. And second, dexamethasone has got a prolonged anti-inflammatory action for about 1 to 2 weeks. In fact, studies have shown that if we give high-dose dexamethasone, the adrenal suppression may be there for up to 1 to 2 weeks. In a disease like croup, it is always preferable to use dexamethasone rather than prednisolone for the simple reason you don't know when the inflammation will worsen. That is one of the reasons in croup, dexamethasone is specifically mentioned instead of prednisolone. So you have to use dexamethasone for better efficacy and for longer anti-inflammatory action. Prednisolone has got a short anti-inflammatory action. It may be good for asthma. For croup, dexamethasone is recommended. In fact, even in the GINA guidelines for acute severe asthma, single dose of dexamethasone 0.6 milligram per kg has been mentioned as an alternative to giving prednisolone for 3 to 4 days. Single dose has been found to be as good as prednisolone for 3 to 4 days.
Great. So simple common viral infection presentation went to like, yeah, Chetan bhai, yes.
Yeah, excellent discussion as expected, because this time we had all brilliant batsmen on the batting pitch, because somebody was asking why everyone, the best people are put in this particular panel. I said because the topic is common, which requires either a gray hair or no hair to discuss, and those people can give you actually good inputs in this particular topic, because this is very common topic, right? Everybody is going to see. But what difference we are going to make it is just the dark hair and either gray hair or no hair, because that experience counts. So one more thing I wanted to say, that when we are discussing about the dysentery, if I'm not wrong, Dr. Balasur can correct me, the first line of treatment is also cefixime, okay, for bacillary dysentery, Shigella. Okay. Now, if it fails, then I think azithromycin has a role as a second line. And then you may shift out to metronidazole. Am I right, sir?
Yeah,
Yes.
two antibiotics, properly chosen antibiotic, and then metronidazole. But azithromycin usually we try to preserve because of various other reasons if you have another antibiotic.
Yeah, so that was like first and second line, then metronidazole. Okay, fine. So overall, excellent discussion. As expected, he avoided those big fives, but still he managed to cover all this viral infection. Hats off to all, including Dr. Jog sir, led by Dr. Jog sir, and all big force. Thank you so much.
Extremely
Sir.
well done. Well done, Pramod. Hats off to you.
Dr. Darul sir, viewers. Sir, you are still
Unmute.
muted.
Unmute. Sir, you are muted, sir.
Sir, you are muted.
Okay. This is a field batting for gray and white hair, he said, but I'm a person with no hair. So to comment on this, it was an excellent analysis with evidence-based reasons, plus the common things that are made complicated by the practitioners with the meager knowledge and meager time to examine. So if they examine and they follow up, there'll be no problem in treating this common viral infections. That is the summary what they have given, if I am right. Thank you.
And in comments there is a caveat, Sri Krishna.
Thank you. I was about to say I'm probably the only one with the maximum hair. more than all of you combined together, probably.
So
Well,
that
thank
was
you, sir.
caveat.
Thank you, Dr.
There are
Chetan,
always
for the
exceptions to the rule,
opportunity
no?
to share stage
Exception
with
to the rule, yes.
seniors like you all.
There are always exceptions to the rules.
Yes, yes.
Yeah, sir. So
Anyways,
thank you very much.
Okay.
It was a really excellent session and perfect timing for this session, pre-winter session. So I think we are going to face all these things in next few months. Hopefully our OPD starts increasing then. Thank you everyone, and hope to see you all again on this platform next month. And thank you everyone. Good night.
thank you, Dr.
Thank
Manish,
you
for
very
hosting the
much.
thing is very nicely.
Good
Thank you,
night.
Dr. Manish.
Thank you.
Thank you,
Good
Joe.
night. Good night,
Thank you very
everybody.
much.
Thank you, sir.
Right.
Thank you.
Good night.
Night.
Really.
Good night.
Bye.
Bye, sir. Bye.
Bye. Good
Bye,
night.
Palvi.
Boss. Not boss, the boss. Good.